everybody, wherever you are on the globe, with the webinar entitled Thinking Outside the Box in Modern Implantology. This is Ziv Mazor, and I would like to discuss with you the latest innovations in dental implantology. Now, I have about 30 years of experience in this field of implantology, and when I started, I almost had no mentors that I could learn from, but you are fortunate enough today to have mentors that can guide you through the process of dental implantology without learning from your own mistakes. Now, the topics that we will address today in the webinar will be utilization of patients' autologous growth factors derived from blood, bone, and teeth. We will talk about the new paradigm shift in implant dentistry featuring the concept of Osseodensification. And at the end, we will feature an innovative new device for tooth bleaching and gum rejuvenation. So let's first start with some clinical examples of the topics that we will address today. So let's take an extreme case of anterior maxillary bone deficiency. And you can see here a lady about 40 years of age, which is going to lose the upper central incisor. And the upper central incisor, you can see exactly where the bone is located, right there. So imagine what happens when we extract this tooth and we want to reconstruct the area. We are also missing the lateral incisor. So what are the treatment options that we can offer that patient? Here we can see the CT scan showing that we have a deficiency not only on the vertical aspect, but also on the horizontal aspect as well. So the treatment options in this particular patient could be either extraction, doing socket preservation, and then doing a conventional fixed bridge. Or we can go for bone regeneration and implant placement. But if we want to consider implant placement in this particular case, we need to do major regeneration procedures because we need both vertical and horizontal augmentation. We can achieve those by either doing socket preservation, GBR, either with particulated bone and membrane, or GBR using bone blocks. We can think about ridge splitting or even destruction osteogenesis. So, first of all, I asked my dental technician to fabricate me a temporary bridge that we can give the patient after tooth extraction, because leaving the tooth was not an option. There was a pathology and there was a periapical big lesion and pain. So we extracted the tooth, and that was followed immediately by doing some type of socket preservation. And one of the nice materials that I like to work with when doing socket preservation is calcium sulfate. Calcium sulfate in a form of a cement that hardens after about 20 seconds. And this is a material which is manufactured by a company named Ogma, and it is called 3D bond. So we immediately place here the material, and then we are able to place a collagen sponge and then reconstruct the ridge. So here you can see the clinical slides, and you can see how we started and where we are just after doing the bone reconstruction. Now, that is not the end of the story, because we have to think how to regenerate the bone. So we went ahead and we decided here to do an innovative approach by doing a sandwich technique. Instead of getting to the gingival margin and start doing vertical incisions and then get recession, we decided to bring down the entire block of bone together with the soft tissues. So here you can see the cut, which was done by piezo in three aspects. And then everything was pushed downward, and then we get the space. And the space is going to be filled with our graft material. This is why we call it the sandwich procedure. So we are fixating the defect with bony plates. You can see here the material that was inserted in between, that was xenograft, and everything was covered with a PRF membrane that will bring all the growth factors and the macrophages to the area to promote bone healing. So later on, we are waiting. That's the end of the surgical session. So we cut off the pink portion of the temporary bridge. And now you can see immediately the difference between how we started and where we are just after one surgical procedure. But again, we have to wait. 5 months later, we open up the area, and then we can see here a complete reconstruction of the bone. And then, of course, we are able to do our osteotomies to insert the implants. And I preferred here to use narrow diameter implants in order to get enough thickness of the buccal plate. So implants are inserted with a high insertion torque in the regenerated bone. And you can see the two implants here that are located one next to the other. And then, of course, we apply again PRF and a little bit of mixture of PRF and biological grafting material, which was a xenograft in this situation. And that was placed on the buccal aspect to gain more of the buccal dimensions. And you can see how much we love PRF when we do our regenerative procedures. So now we are covering again everything with PRF membranes that are manufactured by the patient's own blood, which is taken right before the surgery. And you can see here the outcome or the result after the healing. So now it's completely a different story between how we started and how we finished up. And of course, that enables us to do the final reconstruction, and doing a central and lateral adjacent teeth with implants, that's not really an easy task. So here is the final result, and the 6-year post-op and a CT scan that was taken 6 years post-operatively, showing the long-term stability of our treatment. So that was the first case, which showed you a little bit of an innovative thinking outside the box. Let's take another one, an extreme one. It's a 61-year-old female with a problem of failing old implants in the upper jaw. And you can see that she has been seeking for a solution for the last 5 years or so. And that's really a major, I would say, challenge to reconstruct such a patient. So when looking very carefully on what actually we have, we can see that basically there is almost no bone available. So you can see on the left hand side that there is no bone, not on the horizontal dimensions, and of course not on the vertical dimension. You can see how the implants were positioned inside the incisive canal, and of course all the bridge is mobile. So we think about what kind of treatment plan should we offer the patient. And here you can see how I can move the bridge, and literally I can take it just with my fingers. And when I expose the ridge, you can see the amount of ridge atrophy that we are dealing with. Now that was quite a challenged situation, And the treatment options, of course, could be either doing GBR with blocks or GBR with particulated material and a membrane, or going to a maxillofacial approach and do Lefort 1 osteotomy, or maybe use zygoma implants. My decision was to do it in the simplest way. So we extracted, took out the reconstruction. That was not a difficult task, and you can see the parts that were taken out. And then we started with doing a sinus augmentation procedure through a lateral approach on the right side. And you have to be experienced because sometimes you can run into problems. And here we had a small perforation that I had to manipulate by placing a membrane, as you can see here on the middle. And then we placed the graft material through the window. And that was followed later on by condensing the graft material and placing again another material which comes in a form of cement. It's a cementable material that hardens after just a few seconds. That's a material again manufactured by Ogma, which named bond apatite. It's again calcium sulfate together with HA particles that will last longer than the calcium sulfate. And as you know, calcium sulfate is a material which is also angiogenic, and it's a synthetic material. So we are using that material as our buccal window for the sinus, and then I applied an additional membrane in order to get long-lasting results. On the lateral left side, we decided to do the same, to go and do a sinus augmentation procedure. But once we just outlined the window, immediately the membrane was so thin that we had two perforations that joined together to a one huge perforation. So what I decided to do is, of course, go ahead and do a modification of what we call the Loma Linda pouch. So we are inserting a big collagen membrane tacked on the buccal aspect, as you can see here, and now we can easily place our graft material inside. So that's what we did here on this side, and again on the buccal aspect we applied hydroxyapatite with calcium sulfate, the bond apatite material. A little bit of some particulate, membrane, and everything now is being covered. So we closed down. Still we had some one root that we are going to take out on the second stage. And you can see here that after second stage, the situation has improved dramatically from the left to the right. So we have now bone in the posterior area on the right side. We also gained bone on the anterior part, because remember we had a knife edge ridge. Now we have more to work with on the second stage. And on the left side, we also gained some bone, especially where we had this perforation. And you will see later on what we do with those areas. So that is the clinical situation of the ridge now. Looks much, much better. And on the second stage, that was done again under sedation, we first drew blood from the patient in order to get PRF with all the advantages of using those autologous growth factors. And now you can see the difference between the right side, that's how we started at the beginning, to the left side, how it looks after just 4 months and by placing the bond apatite and doing the sinus elevation. We go ahead now to the front region. So we gained some horizontal height. We didn't do anything regarding vertical, and that's what we are going to do right now. So we are going to do here nasal floor elevation. A nasal floor elevation is a procedure which is quite similar to a lateral window approach, using almost the same instruments, and lifting up the nasal floor and filling up the space with a biomaterial. And you can see here the xenograft that was used here in this situation, and that enables me to immediately place implants. And you can see the implants, which are again soaked in PRF solution. So both implants are inserted together with the graft material. And now we are able to go to the left side. And on the left side, we use those instruments, which are called osteotomes. And by the way, I'm not using osteotomes anymore, and you will see later on in my presentation why. So that enables us to place now implants on both sides, both on the right and both on the left. And we are in a situation now that we have enough implants that we can do an immediate loading protocol. So I decided to load on 6 implants. The other 2, which were not that stable, were left unloaded. And again, some additional calcium sulfate with HA material on the buccal aspect. Now we are in a situation that we can close up, of course placing PRF underneath our flap, and then we are able to take impressions. We don't even need to use a tray because we are fixating the implants with a rigid material. And then we inject the flowable material and then the flowable putty. We can take the impression out, and we are going to send it to the laboratory to deliver us on the same day a fixed temporary restoration. So here is the fixed temporary restoration that was delivered at the same day, and that was given to the patient, and you can see a post-op panoramic x-ray of the patient after he had been delivered with the temporary restoration. Here you can see a few months later, we can now take an impression of all the implants. All 8 implants are now being taken care of, and we can do the final restoration. And remember how we started with that patient. We gave her again the profile that she so much needed. And here you can see a post-op 2.5 years later of the same patient with a long-term stability of our restoration. So you can see how we started, and by doing some surgical manipulations with bone augmentation, we have reached a solution that was suitable for the patient, and she is so thankful and appreciative, and that's what gives us the drive to continue and doing those type of procedures. So here again how we started and how we finished up. And of course, happy patient is our goal. What about I've been talking about using autologous growth factors that are derived from the blood. What about growth factors and graft material derived from the patient's own tooth? Well, we know that teeth can generate bone. And we also know that there are a lot of similarities between teeth and bone because they are coming from the same genetical origin. They have a similar chemical composition, both the dentin and the bone, and they both contain those growth factors which are so much needed, like BMPs, IGF, PDGF, and TGF. And there was a nice article that was published by Schmidt in 2005 showing that those growth factors are preserved in these teeth for centuries and can be utilized. So here is a novel procedure for bone augmentation using a processed extracted teeth. So instead of throwing away the patient's own teeth, we can use them as a graft material. And that procedure was very nicely described by Professor Binderman. And the protocol contains first cleaning the teeth, place them in a solution that is like a sterilizing agent that destroys all bacteria, endotoxins, and so on. And then we bring back the normal pH by adding phosphate buffer saline. And I will show you here the histology and the connection or the interface between the bone and the dentin. And on the right hand side you can see here newly formed bone next to dentin particle. That was the article that was published by Binderman in 2014 showing the procedure. So let's take a clinical example of a patient of mine that needed sinus augmentation on the upper left side, right here, exactly here. So what I decided to do first is extract the teeth, clean them up, put them in the sterilizing solution. Then we can go ahead, put it in the grinder. It looks to you maybe like a coffee grinder, but this is a tooth grinder. 3 seconds, sorry, for grinding and 20 seconds for sorting. Then I can do my lateral window, and I'm loading the graft material in a syringe into the sinus compartment and placing my implants at the same time. Now we can wait, and after 5 months you can see the post-op CT scan verifying the positioning of the graft material around our implants. Taking biopsies, again showing new bone formation around the dentin particles. And now we can move ahead, do our final impressions, and finish up the procedure. So we can utilize the patient's own teeth as a graft material, and this is what we call green dentistry. Now, using PRF is a huge advantage. It's free. It almost doesn't cost anything, and you just need to be experienced in drawing blood or doing phlebotomy for your patients. So now you can actually see another case, which, by the way, is a very extreme one, of advanced periodontal case with a couple of implants that were placed many years ago. And that patient comes and seeks a solution. And you can see, according to the x-rays, that almost all those teeth are hopeless. And there is no way that we can save these teeth. So we decided to extract those teeth, also taking out the anterior implant, and then do bone regeneration, implant placement with immediate loading. And the graft material that I was using in this case was again the patient's own teeth. So you can see how we process the teeth, mixing the articulated dentin with liquid from the PRF. And then we can use the PRF to fill up all the defects for doing the sinus augmentation, which was done subcrestally here. And then, of course, filling and covering everything with the PRF membranes. So immediately the patient goes out with a temporary restoration. And that was the amount of graft that was left after we finished up all the augmentation procedures. Next session was the lower jaw, and we did something which was quite similar. So we extracted all teeth, as you can see here, and again processed the teeth for a bone augmentation and regeneration. And now you can really visualize the defects which are present around the teeth and of course would need to be grafted. So here we took the dentin material, applied the PRF with some fibrinogen, and we can get now what we call sticky bone or PRF block. And that can be utilized to cover all the defects, as you can see here, and everything is covered with PRF membranes. So now we can close up the areas of the augmentation, do the immediate loading here on 7 implants, and then we can take a post-op CT scan to see the outcome of our treatment. So here you can see the bone regeneration that was carried out in the upper jaw, and also in the lower jaw. And actually here you can see a post-op CT scan with the final restoration that was taken 2 years post-operatively. Here's the trying of the restoration. Patient was very, very happy. This is for growth factors which are taken from patient's own teeth, autologous growth factors. Now we will move to the second subject of our webinar, and that is quite a revolution in implant dentistry, and we are referring here to osseodensification. When Brennemark came with the idea of osseointegration, he was stating that there are 6 factors for reliable osseointegration: implant material, implant design, surface conditions, status of the bone, surgical technique, and implant loading conditions. In 2004, the same group of Brennemark came out with the statement that it seems that improvements in surgical technique will present good prospects for improving clinical results. And it took almost 10 years for these improvements to get into our field, and this is osseodensification. Now, what is really osseodensification? It's a low plastic deformation of bone tissue. So actually, when you look on the left, you can see the conventional drills which are used by probably most of you. Those drills were taken from carpentry and metal industry. Those are not drills that were designed to drill into living tissue or bone. On the right-hand side, you can see the osseodensifying drills, which were invented by Dr. Hu Weiss from the US. And those drills are cutting in a reverse mode, not in a clockwise, but in a counterclockwise. So you can see the differences in the drills between the right, which is a conventional drill, and the left, which is an osseodensifying drill. And that drill creates, like you see here in the liquid, it's like a tornado in a bottle. It doesn't cut bone, it only preserves and pushes the bone sideways and apically. Here you can see histology, a specimen of histology after doing osseodensification, showing you on the right-hand side the bone to implant contact with osseodensification, as opposed to the left side where you can actually see that there is very little bone which attaches to the implant surface. So first of all, there were validations of this novel treatment plan on tibia from porcine. And you can see here the drills which were used for the tibia. And here you can see the differences between the insertion and removal torques between conventional drilling and osseodensification, which is in the green. On the blue, this is conventional drilling, and the green is osseodensification. So you can see that there is a remarkable difference between the insertion torque and removal torque between normal drilling and osseodensification. On a micro CT, you can see very clearly on the left-hand side the osseodensification with the white hila or white ring around, and that is due to the fact that we are condensing the bone particles sideways and apically. Here on the right-hand side, you can see a typical picture of osseodensification. You can see the bone particles which are immersed on the sides of the osteotomy, and of course increase the stability of the implant that will be inserted. Here again, the same phenomena on the micro CT. On the apical portion. And here is an histology that was taken at day 0 with significant difference of bone-to-implant contact between the left, which is standard drilling, and the right, which is osseodensification. And again, you can see here the histology between osseodensification on the right-hand side and normal drilling on the left-hand side. An article that came out in 2015 by Weiss and Meyer again was showing the advantages of using osseodensification by increasing the bone mineral density and by increasing implant stability, bone-to-implant contact, and that reduces the amount of micromotion. So with immediate loading done with osseodensification, there are no issues of losing stability. So the same concept was validated in animals, in sheep, which simulate low-density bone. Again, 3 types of drilling: regular, clockwise, and counterclockwise. And immediately you can see again the difference, and that's 3 weeks post. On the left-hand side, you can see the histology of the implant that was inserted with osseodensification, and on the right-hand side, you can see the implant that was inserted with standard drilling. And the graph shows you the difference between the insertion torque of regular drilling versus osseodensification. So it was validated in animals as well. As you can see here, again, the differences in the histology. And Paolo Trisi from Italy was doing a very nice research again on using osseodensification for bone expansion, and he was finding the same principles, that bone powder, which is pushed with osseodensification, is involved in early bone formation. The micromotion with osseodensification was less by 50% as with conventional drilling, and of course there was also an increase in bone volume by 30%. So let's take some clinical examples of using osseodensification. Here you can see a typical example of a fractured molar, lower molar. You can see the deep pocket. Of course, the tooth needs to be extracted, and instead of doing socket preservation as we have done until some years ago, we can immediately take our osseodensification drills and drill in the septum, enlarge and expand the septum to a wide diameter osteotomy that will enable me later on of course, to place an implant. So it's a procedure that takes only a few minutes, and in a few minutes you can see the huge difference between the left side and the right side with an osteotomy of about 4 millimeters. So now we can insert immediately the implant, and of course the voids will be grafted with the biomaterial. And when we check the stability of our implant, you can see we reached 78, and that's a very high number. From 69 and above, we can actually do immediate loading. So here, again, another example of using osseodensification, not just expanding the septa, we can also expand the ridge. And here we are looking at a very extreme, difficult case with a very minimal amount of bone, especially in the horizontal dimensions. We are talking about a width of maybe 2 millimeters in some points. And that patient refused to have a sinus augmentation procedure, so I offered the patient doing just ridge expansion in the anterior regions. And you can see here the plan that was for at least 5 implants. Distal implants were supposed to be a little bit tilted. And now we can see how we carried on the procedure. So first of all, we reflected a full mucoperiosteal flap. And here you can see that what I was showing on the CT scan is actually in reality as well. We have a very narrow ridge. So what are we going to do? I'm placing the guide. I'm doing my first initial osteotomies just by using a pilot drill. And then everything will be carried out with the osseodensification drills. So you can actually see how much expansion we can get by just using the drills. And remember, we were talking only about a 2 millimeter diameter ridge. And by going sequentially, expanding the ridge, we can easily now place implants. And not only that, but this is a 3.75 diameter implant placed originally in a 2 or 2.5 millimeter ridge. And there is no buccal dehiscence. So now we can check also stability, and that was very high. And that enabled us, of course, to do immediate loading as well. Here is our PRF block that was placed on the buccal aspect to preserve the buccal thickness, and everything is covered with PRF membranes. So we are utilizing all the concepts that I've shown you before. Now we can take impressions for immediate loading, and the patient will receive the same day a screw-retained temporary restoration, as you can see here. Taking an X-ray on the same day, you can see here the post-operative situation. And later on, you can see the temporary restoration with the implants. And now we are about to wait between 4 and 5 months before the final restoration. Another paradigm shift in maxillary sinus augmentation had been carried out again using osseodensification. Because what we were doing, and those are pictures of mine taken from almost 20 years ago, when we did sinus augmentation, we of course went to do lateral approach, and here you can see a lateral approach that was done 20 years ago with all those principles of waiting about 9 months, then coming back, placing the implants, waiting additional 6 months until the restoration. Here are the xenograft particles interconnected with new bone. And then later on, we finish the prosthesis, and you can see the same patient 19 years later with a post-op. Long-term stability of our restoration and graft material. So you can see here the CT scan that was taken preoperatively, 9 months, and 20 years. No change. Now, how can we utilize the new treatment modality of osseodensification doing sinus augmentation procedure? And the idea, of course, is to create more with less. And that slide here shows you the entire idea. Because actually, by using those drills in reverse, we push the bone sideways and upwards. And by pushing the bone upwards, that will lift the Schneiderian membrane up. So we are not in direct contact with the Schneiderian membrane at all. Let's take some clinical examples. Here is an upper molar that was to be extracted because of a fracture, as you can see here. So I extracted the tooth and then went ahead, and in the furcation area we went with our osseodensification drills, and we are now lifting up the Schneiderian membrane. We can place, of course, additional graft material which will be propelled up by those drills, and taking a postoperative x-ray shows you very nicely the amount of bone that was added around the apex of the implant, as you can see here on this CT scan. So here is an example of a case that was one of my first cases to do osseodensification, and let's concentrate on the right hand side. And what we can actually see here is that we have about 4 millimeters of residual bone height. So we go ahead and we start to do osseodensification. And now we are going to utilize the tooth that was to be extracted as our graft material. That will be inserted inside, pushed up by those burrs, and that enables us now to place those implants in the back with sinus augmentation. An additional osteotomy preparation in the front where the tooth was extracted. And now we can go ahead, do immediate loading of the anterior implant, and taking an x-ray, you can see on the left the situation on the day of the surgery, and on the right you can see the situation 5 months later. When we take a closed look, you can see immediately the differences and how much bone we have achieved around our implants just by going subcrestally and doing osseodensification. And here is a 3-year post-op of that case. Another example here, again, typical osseodensification procedure that can be done by just going subcrestally. We can push the limits. I do not advise you as beginners to go to such extreme situations like here on the right hand side where we hardly have any bone left. But again, you can utilize the principles of osseodensification here by going and lifting up the Schneiderian membrane, just going subcrestally with the burrs, placing the implants, and you can see on the post-op x-ray the bone that was added around the implants. So here you can see from left the pre-op and on the right the post-op. On a higher magnification you can see the differences. Once you are familiar with this treatment modality, it will change your entire practice, as it did to mine. And here, just to show you, this is a contraindication, of course, for a crestal approach, but just to show you that if you follow the protocol and you are very careful, and here I was using Novabone as a graft material to lift up the membrane, placing 2 implants with osseodensification. And here is the post-op result. Of course, it's a big advantage both for the operator by reducing the treatment time, and of course to the patient by reducing all those post-ops which are associated with conventional lateral window technique. Here is the last case that I want to show you with osseodensification, again an extreme one of an aggressive periodontitis patient that had only 2 millimeters of bone height left. And again, I was extracting the tooth and using it as my graft material with osseodensification. So we go ahead and we are able now to place 2 implants which are 5 millimeters in diameter. And here you can see the post-op CT scan that was taken for those patients. So befores and afters, and 5 months later we are able to finish up the prosthesis. This is a screw-retained restoration, and we have a follow-up of that patient, by the way, of up to 3 years right now. And the picture on the center was taken almost 3 years post-operatively. We just submitted for publication an article showing this type of treatment modality of subcrestal sinus augmentation with more than 230 sinuses done, with an overall percentage of implants integrated of more than 97%, and this is correlating exactly to the same numbers that were published for lateral window and subcrestal sinus augmentation procedures. Now, to finish up the webinar, I want to bring your attention to another innovation in the dental field, which has nothing to do with implantology, but has to do with aesthetics and gingival treatment. And I'm talking about a new device which is called Brightonics, which is a device both for tooth bleaching and gum rejuvenation. Now, the device was invented in Israel, and we all know that aesthetics is a major issue, and personal appearance is very important in today's society. And often we are called to respond to our patients' requests that are wishing for a perfect smile. Now, of course, everybody wants teeth that will look natural, like pearls, and of course should be white. And we know from the literature that over 90% of adults agree that an attractive smile is an important social asset. And of course, everybody remembers someone that has a very attractive smile. And of course, an unattractive smile is not attractive to the opposite sex. So we all know the importance of having a good and a nice smile. The International Organization for Standardization defines tooth bleaching as removal of intrinsic or acquired discolorations of natural teeth through the use of chemicals, sometimes in combination with the application of auxiliary means. So how do we do tooth bleaching? We have some problems. We are dealing with either intrinsic causes, which are stains that are within the tooth. Those can be caused by different types of problems like pulp bleeding, for instance, or taking medications like tetracycline stains, as you can see on the slides at the bottom. And they can also be not just intrinsic, but other factors that can influence those spots can be also fluorosis. And here is a typical examples of fluorosis, which are very difficult to treat. And there are also extrinsic causes for stains and discolorations. And for instance, ingestion of food, beverages, or contact with other pigmenting agents, as you can see in the slides. And smokers, of course, with the nicotine. So what are the current available whitening techniques that we utilize today? We can do either in-office bleaching, or we can do a home bleaching, or a mix of the two. By doing external bleaching of especially vital teeth, it involves the application of substances like carbamide peroxide or hydrogen peroxide. And the steps are first cleaning the teeth, protecting the gum, applicating some type of a gel, and then applicating special light, different sources, and after a period of time we take off, remove the gel, and we get the bleaching. Now, in-office bleaching usually takes about an hour, and of course it requires a special lamp that activates the product. There are products that are activated by halogen plasma. Some are activated by other forms of light. And those, of course, are very much very common agents. And here you can see typical examples of doing the in-office bleaching. On the left, we have to protect the gingiva by applying some kind of material. And then we can place the agent, or the carbamide peroxide, or the hydrogen peroxide, and then administer the light. So you can see different types of situations and materials. Home bleaching involves creating a tray, and the patient receives again a gel, usually carbamide peroxide, that is utilizing it either during nighttime or several hours during daytime. There are also stripes with the same type of materials that can be applied on the teeth. But there are drawbacks which are associated with peroxide treatments, as we all know. And it's time consuming, both office treatments and also home treatments. There are also concerns for many years about the safety. There are also drawbacks not only regarding safety but also about sensitivity that most of you are familiar with. So tooth sensitivity and gingival irritation are the major complaints. We don't know if there is damage for a long term. It was not reported, but there are some concerns. Of course, we can get transient burns due to the leakage of the material to the gingiva. And here you can see, especially in thin type of gingiva, that might be a big concern. So pain is one, and you can see here some burns that were caused by the material that was not, the gingiva was not protected enough. So, is there another solution? So here is the new invention, the Y10 Brightonics, which is an effective tooth whitening agent that works much faster, and it's much safer. Faster, meaning that tooth whitening can be carried out in 30 minutes, one single procedure. And of course, it eliminates the need for home follow-up treatment or home bleaching or whitening. It's safer because it provides a peroxide-free treatment approach. There is no peroxide involved in this treatment modality. So how does it work? It works on low power radio frequency system. So the patient actually has some kind of a bite which is connected to a machine that circulates a low power radio frequency. Here is the technology. The steps. Stage 1, there is RF or radio frequency current which catalyzes whitening toothpaste ingredients which are carried out into the tray that the patient has by charging the molecules with an electrical current. The charged molecules change their form into an unstable molecules, and then at stage 2, the teeth stains that contain chromophore are getting into contact with those charged molecules, and the changes in the current polarity brings all the chromophores outside the tooth, and that's how the tooth becomes whiter. So this is the technology. That's how the device looks like a big iPhone. On the left, you can see the toothpaste, which is inserted into the bite. Here you can see a close look at the bite. And now let's take a look at a video that will show us the Brightonics.
Brightonics. Faster, safer, brighter.
Brightonics is proud to present the Y10 and lead the revolution in teeth whitening. In this short video, we will learn about Brightonics' revolutionary new way to whiten teeth and its associated benefits. All the dental practitioner needs to do is install the disposable mouthpiece in the patient's mouth, then turn on the Y10, and after only 30 minutes, the treatment is completed by simply rinsing the patient's mouth with water. The treatment has a number of advantages. 1. No need to prepare the personal mouth tray. 2. There is no setup time. 3. It does not involve hydrogen peroxide. 4. Chair time is only 30 minutes. Brightonics' revolutionary method more than halves the traditional whitening treatment time, meaning significantly more patients can be seen. Treatment can be successfully performed, even on very dark shades, which currently cannot be treated by existing solutions. Furthermore, avoiding the use of hydrogen peroxide prevents associated pain, side effects, damage to the surrounding jaw, as well as burns that may appear following treatment. We invite you to join the Brightonics revolution. Brightonics. Faster, safer, brighter.
Okay, so I think we are back. So here you can see the before and afters by using the Brightonics. The shades which are changing here from A1 to B1. 2 shades here. Here, 3 shades. 6 shades. and even 8 shades, as you can see here. So again, as you can see here, there is a big improvement, and again, without using any peroxide agents, without any post-operative complaints. That treatment can be, of course, repeated, but the concept is not only about the whitening, but it's also about mouth or gingival rejuvenation, because the ingredients of the Y10 Bright Tonics are not only a toothpaste that contains sodium fluoride and potassium nitrate and peppermint, but also hyaluronic acid. And we know that hyaluronic acid is an agent that promotes rejuvenation. It is used in plastic surgery and, of course, can be used also in mouth rejuvenation. So we have collagen remodeling using RF current, and we are using RF current when we do our whitening procedure. So the mechanism of action might be similar to the dermal tissues. Not only that, but also applying hyaluronic acid, we know from different studies and articles that hyaluronic acid has a direct effect on gingival rejuvenation. So there is a study that is being carried out as we speak on examining the effect of those components on gingival rejuvenation. So those are the items that I wanted to address in this webinar. I'm sorry for the technical problems that we had last time, but I hope you all enjoyed the show. And I'm looking forward to meet you again in the near future. And if any of you would like to contact me, please go ahead. My email is mazor2@yahoo.com. I will be very happy to answer any questions that you might have. So thank you very much, and looking forward to hear from you. Nicole?